Welcome. It's a pleasure to have you join me for this session of Digital Slide Review and Sign Out, which is a joint venture with Path Presenter and the Digital Anatomic Pathology Academy provided by Path Presenter. So our case today comes from the realm of GI pathology. It's a 5-year-old boy who's had some difficulty gaining weight. And appears to have some degree of failure to thrive. So that symptom, of course, is a very significant symptom that needs to be investigated and implies some difficulty with getting the nutrients into the body in a positive fashion or a net positive fashion. So either insufficient intake, inefficient absorption, or excessive caloric demand can create that sort of a setting where weight gain is impaired or muted. So thinking about that, it also led to some radiological studies in this patient, which revealed an ill-defined duodenal mass that led them then to pursue that further. But in thinking about small bowel masses that we might encounter in a pediatric patient, I think it's a different set of considerations compared to those of an adult. So first off, the malignancies, if it's a malignancy, are going to be a different set, headed by lymphoma or neuroblastoma, much more likely than the more commonly encountered neuroendocrine tumors or adenocarcinomas of the adult population. Additionally, others less frequent encounter tumors like sarcomas are more frequently encountered in this setting in the pediatric age group. GI stromal tumor occasionally can present in childhood as well. But then there are a number of benign conditions which can lead to this sort of a problem and could be related to the failure to thrive. So intussusception usually would be associated with some degree of more severe pain and obstruction, but duplication cysts might be sitting around. Hirschsprung's disease may be less common up near the duodenum than distally. And then, of course, inflammatory bowel disease and rarely infections. In addition, there are a number of congenital abnormalities that might create this situation, such as Meckel's diverticulum giving you a mass, potentially other sorts of challenges related to that if there's ulceration or something like that. And malrotation can also influence present as a mass, abnormal findings on one side or the other, and so can also be confusing in that regard. So this patient underwent endoscopy following the CT findings, and the endoscopy showed here some small bowel mucosa, as you see, looks relatively unremarkable. We see villi, we see inflammatory cells, a little bit of sort of distorted muscularis. But then as we come up here to this fragment here, we do see something that looks a little bit suspect here. So we see these dilated spaces here, suggesting that there is lymphatic either obstruction or potentially neoplasm or something of that sort that's causing this lymphangiectasia in the superficial villus portions of this biopsy. So a further biopsy might show more readily identified nests and cords of these abnormal vessels, which, as you can see here, also continue down towards the base of this portion of the sample. So this lesion was larger than could be readily resected endoscopically at the site of this first encounter. And so it was referred to our institution where the diagnostic procedure, the diagnostic and therapeutic process was undertaken. But it's interesting to consider what this diagnosis of duodenal lymphangioma may imply. So often these are incidental findings, not really clinically significant, and they're just kind of happened upon as you're searching for other issues relative to the patient's health. They're much more common in children, especially under age 5, than they are in adults. Less than 1% of biopsies or samples in an adult will reveal this, even when there's a mass present. And generally, they're fairly small, the sort of size that can be managed with endoscopic mucosal resection, but not always. Now, if symptoms are present, they can include pain or mass effect, other symptoms, failure to thrive, as we have in our case. And essentially, the diagnostic features are those of thin-walled vascular channels that show confirmatory immunohistochemical markers, specifically if they have the lymphangiendothelial marker D240 or protoplanin. That would be considered diagnostic. So here's another sample here from this patient showing you the extent of this lesion here, involving several sonometers of the submucosa, and as we saw earlier, also extending up into the mucosal villus structures. Just a very, very rich network of very thin-walled vessels with little intervening stroma, occasional histiocytes in the lumina, but no red cells. Now, not everything that has dilated channels and no red cells is going to be a lymphangioma, but in general, once you get very large vessel structures like this, red cells are going to get into them if they have that connection. But here we can see, small capillary vessels with red cells in them, but no corresponding connection to these dilated channels of variable size and variable thickness of the walls, as you see here. So this is a nice demonstration of a lymphangioma involving the submucosa and mucosa in this patient. Now, did we get it all? Is this a lesion that's going to recur? Well, there is some risk of recurrence, but it's certainly not a risk of developing further malignancy. So the development of recurrence is usually not a big issue. Obviously, if we can control it early on with the combination of surgical resection and maybe some sclerotherapy, then we've solved the problem for the patient in perpetuity. Interestingly, there are a number of syndromes that can be associated with lymphangiomas, and these include things that obviously are detected usually earlier in childhood, such as Turner syndrome or Noonan syndrome, which are more prominently identified by means of external ectomorphic features in the patient, such as short stature, hairline, ear position, the nature of the hands and feet, and so forth. And occasionally associated with, heart defects, identified by heart defects or hearing issues, and so forth. But Maffucci syndrome may not be detected at an early stage unless we've got considerable asymmetric limb growth along with this short stature. But this can also be associated with hemangiomas as well as lymphangiomas and the enchondromas that we've discussed in previous videos. So I included here a number of additional slides to just illustrate this. And this is a case where the lesion was discovered incidentally as it was associated with the presence of a well-differentiated neuroendocrine tumor. Here, just a very small feature of a portion of that, but you can see again these very characteristic thin-walled, variable or variably dilated and variable thickness to the walls involving the mucosa and submucosa. So our final diagnosis on this case is that of lymphangioma, probably not lymphangiomatosis, but consideration of other sites of involvement would be pertinent, especially in a patient who has malabsorption, as our patient does. So that was put in as an asterisk to be sure to consider that or exclude that possibility clinically if appropriate. Well, thanks so much for joining me. It's been a pleasure to share this little interesting case with you, and I hope that it helps you in your diagnostic efforts going forward. We're always happy to have you join our program and hope that you'll subscribe so that you'll catch on to future releases. We come out usually every week. And if you have questions, comments, suggestions, feel free to reach out to me directly at any of the sites above. So thanks so much, and until next time. Thanks so much for joining me.